evening to all our faculty members today and thank you for joining our DEBTalks, that is DCB Insights into Emerging Technologies. And it is a pleasure to have you all over here. So just before going ahead with the DEBTalks today, I would just like to take you through what Translumina is. And before that, I am Garima Bhatia. I'm associated with Translumina. So Translumina, as it says that we are committed to explore limitless possibilities, wherein a company with solutions in coronary interventions incorporated in the year 2000 with 50 plus countries presence and has been certified with a great place to work with. Translumina has its 5 global manufacturing facilities, wherein 3 is indigenous facilities, and R&D excellence is based at Germany. So talking about our strategy partnerships that are we associated with 8 of them and with 10 years of clinical safety and efficacy data. And the products have been CE marked with over 1 million implants. So our manufacturing facilities are based at basically in Germany and the other one in Dehradun. So yeah, Transcelt is our Asia's largest laser cutting facility, wherein just mentioned about the 10 years of clinical data of safety and efficacy, which is with a Yukon choice and Vivo SR, also available in diabetic subset, CAC and ACS. So just recently, there has been an acquisition of Blue Medical Devices in Netherlands. So the acquisition gives access to a patented and innovative and proven next generation drug-coated balloon, that is the DCB technology. So coming up with a Protege, that is paclitaxel coated coronary balloon dilatation catheter, which is EU MDR certified, which has its global presence in more than 35 countries, and its R&D and manufacturing facilities based out of Netherlands. Protege is EU MDR certified with patented drug application process. Talking about its technology, so Protege has its unique drug coding application process, wherein autopaper technology has been opted to basically come through minimal drug loss transition, and wing seal technology that has corrugation over the surface of the balloon, which ensures effective drug delivery at the lesion site. Just because of its coating application and wing seal technology, it is possible to have multiple inflations with the same device in the same vessel. So that is basically 3 inflations with the same device. Protege is also world's first and only non-compliant drug-coated balloon available with Translumina. So thank you all. I would like to invite you all for this DEBTalks, and the agenda would be flowing like as on the screen. I would like to introduce and welcome Dr. Bharat Shivdasani sir, a senior interventional cardiologist at Jaslok and Hospital and Research Center. So thank you so much, sir, for joining over here. And sir would be taking care of our session today. So, sir, I would like to hand over the session to you, sir.
Thank you, Garima. Thank you for that kind introduction, and to Translumina for arranging this academic program this evening, and friends who have taken time from their schedule and joined online. There is a feast of knowledge on drug-eluting, drug-coated balloons, how to use it in practice. And we have a very, very esteemed panel who are going to share their knowledge with us. And I think without any delay, I'd like to request Professor Dr. Carey Tang from Oak Hospital in Essex in the United Kingdom to take his talk on the newer technology regarding this drug balloon and how to incorporate it in our practice. So, Dr. Tang. Dr. Tang, unmute yourself, please.
There we go. Yeah. So, sorry, you can hear me now, sorry.
Yeah, I can hear you.
Right, good. So my name is Dr. Carl Tang. I work at the Essex Cardiothoracic Centre in the UK. It's a tertiary cardiac centre. So today's talk is on the drug-coated balloon, insights into emerging technologies in this field. So drug-coated balloon is not a new technique. It's been around for a little while. And the general consensus is that drug-eluting stents has been the mainstay of our interventional cardiology. But there is now, recognized disadvantage of drug-eluting stents. And hence, the drug-coated balloon or drug-eluting balloon has now made a comeback, and we've learnt a lot about it, how to get the best result from it, and the use and the indication for it is growing. The general consensus is drug-coated balloon is delivered just like a plain old balloon, angioplasty plain old balloon, but the thing that we recognize is that there are certain things that you need to do. You need to prepare the lesion optimally. You need to ensure that there's the lesion is well expanded, usually with a balloon by 1-to-1 ratio. You could use all sorts of different techniques in order to get that lumen open, such as rotablation, lithotripsy, etc. And generally speaking, you could deliver the balloon and inflate it for anywhere between 30 seconds to a minute. And the residual effect is that you need to have a acceptable angiographic result. This includes no flow limiting dissections, less than residual 30% stenosis, and you may want to do pressure wire and ensure that there is good flow. But generally speaking, is TIMI-3 flow is what you're looking at. So what is involved in the drug-coated balloon? It involves 3 key components. You need a balloon, you need an anti-proliferative drug, and then you need a drug carrier or excipient, which will carry the drug and deposit it onto the tissue in the vessel wall. The way that it's diffused into the wall, it requires a lipophilic characteristics. The active drug molecule is usually in a medium or a transport substance, which is usually neutral, the excipient, and the balloon's got to press the against the wall of the vessel, and the drug diffuses into the tissue, and then have the anti-proliferative effect. There is a recognized minimal drug concentration to have this effect, usually about 3 micrograms per millimeter square. So what is the ideal drug-eluting balloon? You need a good anti-proliferative drug. You need to be able to carry the drug through the catheter into the circulation, into the tissue without embolization and without any systemic effect. The drug's got to cross into the tissue to where it has its maximum effect, and you need an ideal dose in order to ensure that it has the effect that you require. So as an example, this is the WingSeal technology that Protégé does. It's got this folded balloon. The idea is that the drug is within the fold, so therefore there's no drug on the surface of the wrap balloon, and allows you to handle the balloon. There are certain drug-eluting balloon where the drug is on the outside of the wrap balloon, and they can flake off, where therefore it's not ideal. You want it to be so that it doesn't fall off the balloon catheter, where you transferring the balloon up the catheter to the patient. Also, you want the drug to be deposited only in the area that you want, not anywhere else, and you want the drug not to be washed off as it's going up into the circulation up the arm or the leg to the coronary arteries. So it needs to be flexible, allow you to go around bends, and also that you can be applied in all aspects of the coronary tree. So the drug, there's 2 anti-proliferatory drug, usually sirolimus or paclitaxel. Paclitaxel is the most studied and most used. The reason is because it is the one that is easy to carry in a recipient, and it transfers into the tissue very quickly, within seconds. It's also lipophilic. There's a high absorption into the vessel wall. It has apoptotic activity, which is reduces toxicity in the systemic circulation, and it also does the job in reducing proliferation, cellular proliferation. It causes quicker vessel healing and faster re-endothelialization. So drugs, how we're going to deliver it is in this excipient, as I mentioned, and the excipient needs to be able to get the drug into the tissue in a very predictive way. Certain advances in this technology is that now you can use and inflate the balloon several times, like 3 times. So therefore, allow you to treat different segments of the coronary tree without using 3 or 2 or 3 separate balloons. So allowing a coating, which has in this case, the protege is a sponge like that. It only releases the drug under pressure. So when you reduce the pressure, there's no diffusion of the drug. So here's a real life use of it. So this is a case that I did last week. It's a CTO of the LAD. As you can see, there's an occluded LAD, and there's a distal vessel. The rest of the coronary tree in the circumflex is absolutely normal. Just the LAD is the issue, which is, you can see, is occluded here. And there's also a stenosis in the diagonal branch of the LAD. So here's another view. You can see the LAD just here. There's the distal LAD occlusion, and then the distal vessel, which flows very slowly. So what we've got is a microcatheter and a wire. We've got a wire in the diagonal branch at the top here. This is a wire in a microcatheter, which, as you can see, passes through the occlusion. And this was fairly straightforward. You can see you're in the true lumen. And so this is a fairly straightforward procedure in crossing the occlusion. Use a balloon to dilate the vessel. And here you can see that it has opened the vessel. Now, traditionally what we have done, we would have put a stent across there and treated that. But I think in this case, what I decided to do is to treat it with a drug-eluting balloon. So there's a stenosis in the diagonal branch, as you can see. I pre-dilated with a 2.5 millimeter balloon. I'll give you some nitrate. You can see the vessel is grown already just with dilatation. I treated with an NC balloon to prepare the lesion. And again, in the LAD, and then also treated the diagonal as well. So there's a long lesion, and treated with subsequently with a drug-eluting balloon, and this is the drug-eluting balloon going in. It's a 2.5 BEB, and this is same balloon, and then treated again, same balloon. So 3 lesions with 1 balloon. And this is the final result. Now, of course, you sometimes you don't like this. You don't get a stent-like result. There is some evidence of dissection within the CTO lesion, which is now expanded, but nevertheless, it's not flow limiting. TME3 flow, less than 30% stenosis, residual stenosis, and there is no evidence of any dye hang-up, hold up within the dissected segment. You've got to dissect the vessel in order to make the lumen bigger. So that is important. And the patient was discharged on dual antiplatelet treatment. The reason I chose to use a drug-eluting balloon in this patient is because he's got an upcoming urgent cancer surgery, and therefore I did not want to put a drug-eluting stent and therefore prolong the dual antiplatelet treatment. So acceptable result, and I can predict that in a 3-month time, when we bring him back for a check angiogram to confirm that it's all okay, that usually that vessel would have grown, and the haziness of the vessel will recover. So why do we enjoy using drug-coated balloon nowadays with these new technologies? That we leave nothing behind. There's no residual scaffold. There's no foreign body in there. That would then allow us to shorten the need for dual antiplatelet treatment because there is no scaffold or any foreign material in there. There is reduced late thrombosis. What drug to use is between paclitaxel and sirolimus, and then more trials be coming in to compare one or the other. There's better delivery of the drug now with the technology, and the dual antiplatelet treatment that we use are much better. So ticagrelor with the aspirin is very effective in reducing any acute thrombosis, acute dissection, or acute closure of the vessel. So as I said, TIMI-3 flow is acceptable result with less than 30% residual stenosis, no flow limiting dissection, and no significant recoil. If it doesn't fulfill any of this, then you may need to consider a stent. So drug-coated balloon usage is based on limitation of drug-eluting stent. There is indication, particularly in patients, like in this case, a high bleeding risk, because it's elderly, it's got a presentral surgery coming up, so the risk is higher. In patients with in-stent restenosis, in small vessels, we always have been using drug-coated balloons, and now there is more evidence to support that. Just because we use drug-coated balloon doesn't mean that we only use drug-coated balloon. Sometimes you use what we call a hybrid approach, where you put stents in one area and put drug-coated balloon in other areas of the coronary tree. Bifurcation is an example of that. But I won't talk much more about the general advances in the indication for using drug-coated balloon, because obviously the subsequent speakers is going to mention about all these, particularly in in-stent restenosis, in bifurcation lesions, and in patients with a small diffuse disease, such as patients in diabetes. So the idea is leave nothing behind, get a good result. Thank you for your attention.
Thank you, Dr. Tang. That was a real well elucidated talk on the use of the DEB in this particular clinical scenario. And I think more and more of us in practice are going to face that, because as life expectancy grows, patients are coming up with non-cardiac problems which need surgery. And this offers a very, very good practical solution in such cases. And as you said, the result was very good. It was a very good use of this technology, especially what you spoke about, inflating it 3 times. Now, up until this particular balloon and technology is available, our conventional practice would have been 1 long DEB to the LAD and 1 short DEB to the diagonal. So this has really worked out well. And the concentration of drug released in each inflation, Dr. Tang, you think that it is sufficient and is delivered adequately, in these multi-vessel scenarios?
Yes, there is clearly, each time you inflate it, it will reduce the amount of drug released. And the first inflation is highest and the third inflation is lowest. With this particular balloon, you inflate it for 30 seconds, not 60 seconds, for the first inflation, for the second inflation. And they mentioned also the manufacturers for the third inflation as well. But I tend to go longer with the third inflation, just to ensure that there's a bit more drug release with things. So I usually inflate the third one for about 60 seconds.
Wonderful. Like you said clearly that, the beauty of paclitaxel is that it's strongly lipophilic and it diffuses very quickly and robustly into the endothelium, which is something which sort of goes against when you had the first generation Cypher versus Taxus trial. And as the first generation drug, cipher fared better. And in fact, I was part of a reality trial which also studied that, the two drugs. So how do you sort of match up these two?
Well, the sirolimus drug has a longer lasting effect once you're in the system. The benefit of stents, it's in there for a long time.
Right.
So therefore the drug could take its time to be released very slowly. Paclitaxel released very quickly. So therefore, with the amount of coverage from a stent over the area is quite small, actually. The stent is a scaffold, and if you're just releasing the drug from the scaffold, then the amount of drug you can deliver onto the tissue is relatively small, particularly for paclitaxel, which obviously diffuses very quickly. So it's gone very quickly. And that I think is probably the effect why, those that have used the paclitaxel Taxus stent feel that it's like a bare metal stent, because it didn't quite do much at all, although it was sold as a drug-eluting stent. And I think it's because the amount of coverage from the stent, the amount of drug release in total in that time is very small, where the balloon, you diffuse it all over with over the covering of the balloon into the tissue. The bigger dose, you get a bigger dose than you would ever do on a drug-eluting stent for paclitaxel.
Right. Ashraful, hi. Just unmute yourself.
Yeah, I am unmuting myself.
Yeah, Ashraful, good evening. I
Good
hope
evening.
your case has gone well. Good of you to join. Okay.
Yes, sir. Yeah.
Now, Ashraful,
Yes, sir.
he is at the very popular Ambry Hospital in Calcutta. Much in demand, and Dr. Ashraful himself is much in demand. Yeah. And I think Saurav Ganguly, if I'm not mistaken, is your patient. And we had my colleagues coming to your
Not
center,
mine, sir.
right?
Not mine.
Okay, so use of DEB in clinical practice, can we have your thoughts on that?
Yes. Good evening, respected chairperson and respected seniors. At the outset, I want to thank Translumina person regarding to invite me to to share my experience regarding drug-eluting balloon. At the outset, I want to highlight that I have very much little experience, personal experience regarding drug-coated balloon. So, so just I want to share that I have done at least 20 cases by drug-coated balloon in last 2 years. And in my hospital and other doctors, other consultants, they have done at least, or overall, we have done at least 100 or 120 cases. We have to take data and we have to analyze this data and also to follow up data, because we in every patient we can't follow up. So then we can share my experience at least with you. That is my thing, and now just I want to share my experience regarding my daily practices on regarding drug-coated balloon. By a case, you can understand the scenario of the case and what would be the best thing to use the stent or balloon or other things. So just I want to share that to understand the importance of drug-eluting balloon, so we have to see the mechanism how it acts. Number one. Number two, we have to check the different clinical evidence or different data so that we can use it in our daily practices. And we have to have our our practical experience how we should use the drug-eluting balloon. And if we want to take the help of the imaging, we can take the advantage of the image, and so that we can utilize the different other modalities to treat the lesion. with if it is required, the drug eluting balloon, we can use that. And build our personal clinical experience with our cases so that we can apply in next cases. And we have to evolve and we have to publish our documents so that we can share our data with other doctors or other hospitals so that we can use in daily practices of the drug-coated balloon confidently. So we have to familiarize with our latest recommendation regarding the guidelines and to establish the guidelines according to which has been established with the ESC and AHA. And clinical indications in instant restenosis, small vessel disease, bifurcation lesions. And we have to appropriately select our patients to use the drug-coated balloon and optimize the drug-coated balloon delivery so that we can optimize the result. And device options stay up to date on the latest DCB technologies, including new developments in coating of balloon and characteristics. I have already discussed regarding the imaging. If required, we should use so that we can appropriately adjust our balloon size for pre-dilatation or preparation of the lesion, and then we can optimize our drug-coated balloon according to the lesion and the vessel size. And begin by selecting a few straightforward cases for DCB use, then progressively move to complex lesions. And then we monitor patients' outcome, complications, stenosis, make adjustments to your clinical techniques as necessary to optimize success. And whatever we have the different clinical studies or trials, I think we have no major trial with this drug-coated balloon, except some trial like Transform 1 or other small non-randomized trial, which are showing the different result in respect to MACE, target vessel revascularization, and stent thrombosis or other clinical outcome. And we have actually decided. So my final thought is expanding DCB practice confidently requires a combination of clinical knowledge, patient-centered care, technical skills, and ongoing professional development. And here I want to discuss my case so that you can understand this use of DCB in this case. I think this case is relevant with my topic. This 44-year female patient was presented to me 4 years back in 3 years back, 2022, with acute anterior MI, ST elevation. That time we non-diabetic hypertensive patient, and EF was now 38%. And that time, actually 2022, we have done a primary angioplasty, LM to LAD. And now the lady came again with chest pain on exertion and after a history of postprandial angina. So this is her latest angiography in 2025 in May. You can see the stent envelopment to LAD, and proximal part is restenosis is evident, at least 60%. And LCX is diseased. I think it may be 50-60%. Back up. So, okay. So in LAD, there is a tight lesion in distal to the stent. In the mid to distal junction, it is around 80-90%. In proximal part, 60-70% stenosis. And LCX is diseased, it is 50-60%. In RCS, proximal mid part is around 80% disease. So this lady is now 44 years, diabetic. Leitman is quite okay. As this patient is health scheme patient, so and at that time the IVAS is not available, so I can't do the IVAS in this patient. So I think this case is open for discussion. What should be the strategy in this patient? So can I will finish the whole thing, or sir, we can share your view in regarding this case.
I think go ahead, Ashraful.
Oh, yes, sir. So I decided that we will go for angioplasty in this patient, and I have counseled the patient party regarding the long-term result. As patient is quite diabetic, at least for 10 years, and there is estimation proximal LAD and also LAD, and the distal lesion is tight. So I have decided to do the angioplasty of the right coronary artery. We have done the angioplasty of right coronary artery by conventional technique at predilation 2.7 into 12 in C at 20 ATM. Oh, sorry. Okay, we go slowly. Back. Yes. So we have done the angioplasty of the right coronary artery by 2.7 into 44, and was dilated with 2.7 into 12 NC balloon, and good distal TME3 flow, and result is good. And then we proceed to then we have proceed to left coronary artery. Sorry, sir. Sorry. And we have decided to do the distal LED lesion to do angioplasty with dilatation with 2 into 15 millimeter NC balloon at 16 ATM, followed by and the proximal lesion we have prepared with it Wolverine 2.7 into 10 millimeter balloon at 12 ATM, and mid distal lesion is covered with 2.7 into 18 millimeter giants. And the we have post dilated the distal lesion with 3 into 15 NC balloon, and the proximal and mid excellent. Well, yeah, during doing the angioplasty of the mid distal lesion, we there is proximal resection, and then we have to cover it with another stent, a 3 into 18 giants at 12 ATM. And then proximal lesion is we previously treated with NC balloon, then cutting balloon, and now we have dilated this proximal lesion with 3.5 into 15 protege balloon at 6 ATM, and we inflated for 30 seconds. And this is the final result. So my strategy was that I should not cover the lesion of LED proximal, at least proximal part with this another stent. and it will cover all the left main also. So in left main, I am a bit scary about to put another stent and double to keep it in double layer. And patient is younger patient. So my instinct was to use the cutting balloon in the stenosis part, and if required, drug-eluting balloon dilatation. And the result is very good and favorable, I think. And distal lesion is we already treated with stent. So this is the one example what it is my clinical what my clinical decision at that time. What should I do with the proximal lesion? Whether I have or I will put another stent, or I will send the patient for CABG. And patient is female patient, 44 years, and she is so scary about the CABG. Then we have to take this decision. Then the best decision at that moment, when I seeing the angiography, and I decided what to do with the proximal lesion. So whether I put another stent and to make it another metallic jacket, and left main also, you can see the left stent is also in left main. So I have to put the stent also in left main.
Ashraful, very, very nicely done. You are the operator and you have to take the decisions on the spot.
Yes, sir.
Maybe I would have looked at it in a little different way.
Yes, sir.
That after you fix the right coronary with one long stent, RCA was good. That
Yes.
seemed to be the immediate culprit in terms of the degree of stenosis. The left main to LAD in-stent,
Yes.
ideally, if you had an IVUS, you could quantify
Yeah.
better as well as size it better. And the mid-LAD lesion actually was ideal just for a DEB. I would have just done a DEB to mid-LAD, and like you did for your in-stent, LAD, left main to LAD, if found really significant, like you've done just the DEB for the stent.
Yes.
So little different, but you've achieved a very good result. And I think that brings home the point of a sort of hybrid therapy in terms of stenting the critical larger vessel and using DEB, in other areas to reduce the overall stent load. So
Yes.
very good case.
So, sir, just a question that came into my mind, like, sir, what is the role of DCB in CTO cases, sir? Just for my information, sir, I would just like to learn about it.
CBA, sorry.
CTO, sir.
Oh, Dr.
CTO,
Tang can
yeah.
take that because his case was a CTO.
Yeah, I think CTO, we used to put stents from top to bottom to cover the whole lesion, but the general consensus now is try to reduce the length of stent. So we tend to stent at the proximal cap, where the problem lies, and distal vessel or some proximal disease, we tend to try and either DEB or we leave alone kind of thing. So it's now a sort of hybrid most of the time. Which, the case that I'd show, I didn't put a stent in that one, but that was quite a simple CTO and straightforward, and I can see there's no side branches or anything of concern. So I think with more and more experience, you tend to leave more because you find out that actually, when you come back to it, we've done a study where we looked at CTO to physiology, bring them back in about 3 months' time to redo the physiology, and a lot of them has improved downstream after you've done a drug-eluting balloon. So the more you do, the more braver you get, the more things you leave. And you don't worry about the acute, what it looks like, as long as there's TIMI-free flow.
So I agree. The whole issue being that when you use the drug-eluting balloon, the late lumen loss is a lot less, and over a period of time, you get the positive remodeling, and these arteries, especially the CTOs, the distal part, tends to grow better once the antegrade perfusion pressure is established and achieved. So as you correctly said, the main area, the proximal to the distal cap is covered by a good stent, preferably under IVUS guiding for appropriate sizing and optimization. And the distal part is tackled by a long DB depending on the length of the lesion. And actually, more and more, I think even in my practice, I'm incorporating this sort of hybrid approach that maybe, the proximal, a large epicardial artery will receive the stent. And then as we go to the mid and distal part, the DEB really, really holds its own and gives you a good result and, good outcomes, as you say, on restudying after even 6 to 8 months.
Yes, I think you just, for those lesions which you get recoil, and therefore they need a scaffold to keep it open. And even if you dissect the vessel, if there's dye hanging, okay, there is evidence of flow limiting dissection, you can just stent the dissected bit and not necessarily have to cover the whole vessel. And that's been my practice. The length of stent is getting shorter and shorter, basically, and because of the drug-eluting balloon, and because with the experience of rechecking, which we don't do now. Once we know there's good flow, we're now brave enough to not to bring them back to check. Before with the CTOs, you put the long segment of stent, we bring them back because the distal stent, it may be too small now because the vessel is grown, and therefore you need to tidy up. And but now because we're putting less and less length of stent, the vessel remodels with no stented segment, and therefore there's no need for us to do anything.
Correct. Absolutely. Dr. Tang, I think very, very recently, maybe a month back, there was some data about the Ultimate 3 trial, which looked at this specific issue about initial late lumen loss and angiographic follow-up at 7 months, and the DEB I think has fared quite favorably, and I think it's increasingly a good option, especially in high bleeding risk patient, those who are elderly above 80, they tend to have a lot of CKD, low EGFR, where the bleeding risks grow higher, that we give them a chance with the DEB. What are your thoughts on that?
Yeah, totally. I think so. I think for now, with the bleeding concerns, and obviously these are the patients that we try to avoid putting a stent in, because once you put a stent in, it's the point of no return for antiplatelet for at least a month. And if they've got bleeding risk, which is high, then it is not going to be good. There is for the patient. And I think now with more and more trials showing non-inferior with the DCB compared to DES, I think these are going to be the patients that we're going to be treating with these drug-eluting balloon. I think for larger caliber vessels, for de novo patients whose the caliber is big, we don't have too much evidence to support that compared to the small vessel. But like most things, clinical practice always precedes before the trials. And as you get more experience, and you're more likely to try and use them to get, if the pre-dilatation give you a stent-like result, then you're more likely to put a drug-eluting balloon in than you would compare with a drug-eluting stent in before and consider a balloon, So it all depends on the angiographic result. If you're pre-dilated, you get a reasonable good result, and then you're more likely that you're going to be good with a drug-coated balloon.
Yeah. So I think there probably will be some data out with a trial which is looking at DCB in vessels 3 and above. But incidentally, just to share with you, so we had a big India Live conference in Mumbai 2 months back, and Antonio Colombo was doing a live case from his center in Italy, and he was like completely large proximal LAD vessel, huge dissection. There was an intramural hematoma, but he still stuck with using the DEB, and distally mid to distal LAD. Fair enough, that was a long DEB that he used, and really using FFR on table and continuously monitoring that. Your first slide showed FFR more than 0.8, but sometimes some trials and some data you could use more than 0.75 and above as a reasonable flow result. So
That's right. I think the trouble is pressure Y in these cases are never been proven because you never use pressure Y for POBA measurements. Usually is before you do anything to them, before you stent, and once you've dissected and then you try to do a FFR, it's never going to be what the study tell us to do. That's the thing. You're going outside and extrapolating. But nevertheless, what you're trying to tell you is that if the flow is good,
yeah,
then more likely you're going to be okay. If the flow isn't good, then those Tibi-2 flow, then yeah.
Okay, Dr. Janeshwar is back, or Garima, have we got any speaker back?
Dr. Bhanja is trying to connect, sir. He just called
Okay.
me. He's trying to connect, sir. Yes. So he'll
right.
be in another second, sir.
Okay.
I think the other thing is that if you are concerned about acute thrombosis, acute closure, I see that much less now that we've got very more powerful dual antiplatelet treatment. And now that you've got ticagrelor, you've got prasugrel, if you're concerned, obviously it's aspirin and clopidogrel for stable patients. But if you feel that this is particular high risk, you might have given them something stronger like ticagrelor or prasugrel, maybe for a couple of weeks, and switch them back into clopidogrel if you need to.
Yes, absolutely.
Dr. Bhanja, thank you for joining here. We understand you were occupied in the case.
Yes, welcome, Dr. Bhanja. He's interventional cardiologist at Chhattisgarh. Go ahead, Dr. Bhanja.
Thank you, sir. Sir, actually, I was actually initially in Apollo for 15 years. So from the beginning, actually, in 2011, when I attended a conference in SCC and TCT, so there was a small one center. They have shown a trial. There were 250 cases of distal lesion and small lesions.
Yes.
By basically paclitaxel stent, paclitaxel drug-eluting balloons from Medtronic. The result was excellent. So after that, when I returned back from that conference, then I tried for last 15 years. Basically, my experience is in stent thrombosis and small, basically vessels and distal lesions. I have tried near about 5 to 10 DEVs per month, actually for last quite 1 decade I am using, and results are excellent actually. Even some patients I did angiogram even after 1 to 2 years. If I compare smaller stents, those who are less than 2.5 and versus this drug-eluting balloons, whatever my experience I am sharing is little bit better if I compare with the smaller diameter stents to the drug-eluting balloons. Even I can say that those who are the lesions which are instant restenosis, if I post dilatation with DEVs, result are excellent. Whatever my experience, this is this balloon basically from I use this fast balloon. Otherwise, I have used in Medtronic and other company. As we knows how it deliver. Already everyone is at the top has I refer. This was actually basically 65 years female. He was a diabetic, hypertensive, and hypothyroid. And basically 2-3 times he has a post PTCA. Now PTCA already also in 2019 TBD. So RCA instant restenosis were there. I got lesion. If you'll see the lesion, this is the lesion in RCA. And this is basically after post DB, if you see, the technique is same. Usually we do it 2 to thrice with the 45 seconds before pre-dilating the lesions properly. And sometimes you use OPNMC also to dilate the vessels nicely. Followed by we prepare the bed, then used DEBs. And results are excellent. Even if, sometimes to see after the symptoms, we did some stress test also, stress echo, treadmill versus echo, sometimes dobutamine system. I have seen there is no changes. Patients are usually asymptomatic, and sometimes we did angio after 1 year. The result are excellent. This is a case actually past DV from this translumina. That's I want to show it. Otherwise, all the DBs, I think the mechanism of action is same. Some I have used sirolimus also. I don't think any difference between sirolimus and paclitaxel according to my experience. And but otherwise, time will tell about this paclitaxel or sirolimus. So basically, DCBs have the potential to address limitation of DS in various clinical and technical settings. New angiographic and clinical scenarios effective in large de novo coronary lesion, suitable for bifurcations, useful in diffuse coronary artery disease, and sometimes it is applicable in acute coronary syndrome also. So the last 2 years have seen significant development in DCB technology and clinical data. Ongoing larger clinical trials with long-term follow-up are needed to validate the efficacy and safety of DCBs in these settings. Thank you.
Thank you, Dr. Banja, and for the case presentation and demonstration. And I think we are going to get more and more data of the use of DCB in such, de novo focal lesions,
Exactly.
which will do away the need for unnecessary stent and prolonged DAPT. And as Dr. Tang was saying, that we are probably reaching the phase and era of less metal, less stent, and allowing the coronaries in a sort of modified it now. The bioabsorbable vascular scaffold had its own challenges, but here with the DCB technology and it evolving and becoming more sophisticated and better with time, that's probably the way that we are headed to.
Sir, excuse me, sir. I did one question to Dr. Tange. Sir, after DBs, is there any chances to post-dilate the lesion? Just after putting a DB for twice or thrice, it will inflate the lesion. So, any chances to after DB?
Yeah, I mean, after DEB, once you deploy the DEB, ideally that should be the final procedure, isn't it? But sometimes you get recoil. You think you may have to pre-dilate, but the question is whether is it going to affect the drug that has been deposited? I mean, the drug should have been absorbed in. So if you need to balloon again, it doesn't happen too often, but I've not had any adverse reaction, and apart from sometimes needing to put a stent in because it's recoiled.
Second question is, suppose in LAD you are putting a stent in the proximal part and putting a DB in second distal part. But
Yeah.
suppose you are putting a DB like about stents, you are putting a giants and putting a paclitaxel DB in the distal part. Is there any interaction of drugs in?
Yeah, I've not come across it myself.
No, so
I haven't done enough where there, you from what I haven't done enough follow-up to be sure. But in one of the CTO trials that we did, we put a sirolimus related stent, a Zion stents down the main vessel, and then we DEB with a paclitaxel balloon in a distal vessel. And those are the only groups that I've brought back to review and not had any problem with those. So I guess I don't think there is enough real life problems. There's always theoretical issues, but in reality, I've not seen any.
So I'll just add on to that. Banja, there is no problem with that, because now for the stented part, you're using now the second or third generation Lima stents. And distally down the road, you're using the drug balloon. Okay, we know that your stent is not going to be Taxus paclitaxel stent, because that went out of favor. But the balloon, like we discussed earlier, probably you were not linked in, is that the concentration of the paclitaxel within the wall and the balloon is sufficient to generate a good term, a long-term result, and less restenosis. And the paclitaxel does not adversely correlate, interact with another generation of drug. And in fact, you all know that paclitaxel is also used as an anti-proliferative drug by our kidney colleagues and several others with good
All
effect.
the drugs are possible.
So there's no issue. You select the best DB technology and the drug, where you're going to use a DB and where you want to use a stent. Depending on the stent characteristic, you can go ahead and use a stent of another drug.
Thank you, sir.
Yeah, I mean, I think, and also putting stents. Sometimes you're supposed to put the same type of stent, same brand stent. But again,
Yeah.
I'm it's all I find that it's all hypothetical.
Absolutely, it is.
I've not really seen anything. Whatever stent size fits, it should be okay. Ideally, if
Yeah.
you can put the same flavor, that's good. But if you haven't got the same flavor, I don't want to lose sleep over it.
Right, exactly. But I would say that, coming to the point about post dilating after DEB, so I sort of don't do that. Whatever best way I have to prepare, whether it's instant or whatever, use your non-compliant, or if you need to modify the lesion with cutting balloon or upscale, or if you want to use a high pressure OPN balloon, do all that before. And in my practice, the DB is the last inflation in that particular area.
And it's there just to deposit the drug, not to expand the lesion.
Yes, not to expand the lesion, and it's done. Okay, Garima, I think with
Yes,
that we've come to the end.
Yes, sir. So, sir, I would like to thank you, sir, for facilitating the session today. And, sir, Dr. Tang, also, I would like to thank Dr. Bhanja. Thank you for joining. Dr. Ashraful, sir, thank you for joining here, taking your time out, apart from your busy, hectic, I would say, routines. So it was a really wonderful session, in exchanging of thoughts and the practices. So thank you and have a great evening to everyone.
All
Thank
right,
you.
thank
Thank you
you.
for the
Bye,
invitation.
everybody.
Thanks, sir.
Thank you.
Thank you.
Take care.